Welcome everyone to the latest instalment in the Interacoustics Academy webinar series. This is a session where we're going to talk about the advanced tests in audiometry. Just a moment to introduce myself. My name is Mike Maslin, and I'm an audiologist as well as an international clinical trainer with the Interacoustics Academy, and we're a group of audiologists who are interested in training and education in the various different audiological and vestibular tests and their clinical applications. And the one that we're going to unpack today, as mentioned, are those that centre around the audiometric procedures. So the concept of the session is to unpack the theoretical basis for a number of advanced audiometric tests, as well as lend some consideration to the clinical applications and the discussion of the procedures themselves and how to interpret the results accordingly. Now, on this slide here, we have a list of a number of different tests that are available on Interacoustics audiometers, typically either diagnostic or clinical audiometers. Now, of course, it would be quite an extensive session to attempt to unpack all of these tests, and so what I've done is concentrated on a select few which are both interesting and relevant to the modern audiological clinic. So the ones that we're going to touch on are the high-frequency pure tone audiometry, the threshold equalizing noise test or TEN test, the Stenger test, and these three I've grouped together. That's the ABLB, alternate binaural loudness balance test, the short increment sensitivity index, and the tone decay test. And I've grouped these three together for reasons that will become more clear later, but these are all centered around a similar clinical application, which is a differentiation of cochlear from retrocochlear pathologies. But I'll come to that later. We'll go through for now the high frequency audiometry test. This is a nice place to start, I think, because it's actually relatively straightforward from the point of view of learning new concepts, because it's the same procedure for audiometric testing as you would expect to arise in the normal audiometric range, which is typically from 250 Hz up to 8 kHz. The only difference here is that we do the same procedure but at a higher frequency range. And as you can see here, above 8 kHz, so usually from 10 kHz up to perhaps 16 or even 20 kHz. And there are a number of reasons for wanting to do this. And some of these are listed here. So for instance, there might be a clinical need to monitor for the effects, the early onset effects of ototoxic medication, which can be administered for a range of reasons, but a common one would be anti-neoplastic drugs for cancer treatment patients. Another one would be monitoring for the early effects of noise exposure or acoustic trauma for those who might work in a noisy environment, for instance. Monitoring for the early effects of age-related hearing loss, and also if there is a need from a management point of view, managing a patient with a hearing loss, to fit a wideband hearing aid for some particular reason. So there's a number of different clinical applications here, and as mentioned, the procedure themselves is much the same as pure tone audiometry that occurs in the sort of standard audiometric range, with a few small technical details, mainly centered around the need for specialist headphones, such as these Sennheiser models that I'm displaying here, that are specialized for high frequency testing. Now, I'll just unpack one of those applications just in a little more detail, and that's monitoring for early onset hearing loss in adults. And the reason why I'd just like to centre on this one is because in recent years there's been a great deal of interest in understanding the effects of very high frequency hearing loss, for example, on patients with tinnitus, and also there's increasing discussions, certainly in various parts of the developed world, for the introduction of screening for hearing loss in adulthood, as adults go through to sort of the older age group. And hopefully the reason for potentially applying a high frequency audiometry in this group is conveyed by the information on this slide here. Because on the left we see a schematic of the basilar membrane, which is just expanded there from where you can see its position in the inner ear to the in the middle part of the diagram, and then where the inner ear is located in the head on the very right hand side. But if we just concentrate our attention on the left, then it's clear to see that in the very basal part of the cochlea, and I'll just use the pointer to illustrate where I'm meaning here, then the sensitivity of the ear extends quite substantially upwards in frequency terms, beyond the 8 kHz range that we typically test in pure tone audiometry. So there's quite substantial scope for hearing loss that would not be detected using the standard audiometric range. But because this region is in the basal part of the cochlea, in terms of the cochlear spiral, then it's particularly susceptible to damage, mechanical and noise trauma, and just general, sometimes described as wear and tear that you would get as the person goes through the aging process. And it's because the traffic, essentially, the acoustic traffic, the mechanical energies that vibrate along the basilar membrane, everything has to pass through this high frequency range here, these characteristic frequencies. And so if there is age-related or noise trauma, then you might expect these regions to show very early signs before the lower frequency range in the normal audiometric range perhaps becomes itself affected. This this slide here just illustrates the reason for why we typically test in the audiometric range, because what we see on these two audiograms is the shaded region in the middle, sometimes known as the speech banana, and it's around about a 30 to 40 dB dynamic range that we see here for the right and left ears separately, which would correspond to the range in which both frequency and level that sort of quiet to normal conversational speech occurs, as well as other day-to-day sounds. And here we have on the left and on the right, separated according to female and male, the typical expected pattern of age-related hearing loss, which is broken down. Each of these lines on the audiograms that you see here is broken down according to the age group, and so we can see that as the individual gets older, this is group level data here, but as an individual gets older, then the hearing sensitivity gradually declines, but that decline is slightly greater in the higher frequencies for the reasons that I was just mentioning. It's due to the tonotopic layout of the cochlea, with different characteristic frequencies along the basilar membrane and the higher frequencies towards the basal end of the basilar membrane. And the pattern, as you can see, is quite similar for females and for males here. It's the severity of age-related loss is typically slightly greater in males, and that can be for socioeconomic reasons to do with professions and so on that a male might do as compared with a female typically. But it's the same pattern. And here we can, of course, we can see by overlaying these results over the top of the speech banana, we can see where some of the communication difficulties lie, because quite a large proportion, as we get older and older, of the speech becomes inaudible, as well as another proportion that becomes only just audible when normally it would be very audible. But if we were to extend this audiogram into the high frequencies that we were just talking about before, above the normal audiometric range, then that's what I'm showing with these dotted lines, and these are just the thresholds extrapolated into the high frequency range. And so it was hopefully clear from this that you might stand a greater opportunity to observe hearing loss from an earlier age, and of course the earlier that you understand whether a hearing loss is present, then typically the better you can manage the patient in terms of the correct counselling, and usually any more active proactive interventions such as hearing aids and so on, usually the outcomes are better if the individual adheres to using those or adheres to those management options, hearing aids and so on, from an earlier stage. So some of those concepts are just mentioned by bullet point here. So of course it's well known that many people take a number of years to first think about their hearing loss. So if we were to identify it at an earlier stage, then it may be that those different management options can be implemented from an earlier stage. And as you can see from the third bullet point there, early intervention may well result in a better patient experience, of course, but then that would translate into cost savings on a population level. So that's age-related hearing loss. Also, just well worth taking a moment to mention the phenomenon of tinnitus in the case of a normal audiogram. And it's generally accepted that tinnitus is triggered by hearing loss. But there's a certain enigma surrounding a small proportion, around 10% of tinnitus cases, where there's no apparent hearing loss. And so they're described as cases of tinnitus with a normal audiogram. But it may well be that they have triggered tinnitus because of a hearing loss in the higher frequencies that perhaps weren't routinely tested. And that might explain a large proportion of that 10% group. And of course, again, that would lead to the option of perhaps more effective management, certainly counselling, as well as differential diagnosis of the tinnitus. And the same would apply to other hearing complaints, not just tinnitus, but other hearing complaints where the audiogram in the normal audiometric range is apparently normal. It could well be worth extending the hearing threshold assessment up into the high frequency range. So that's something about high frequency audiometry. Let's now move on through to the next test in our list, and that's the threshold equalizing noise test. Now, this is a particular test which is applied when there's some suspicion of a dead region in the cochlea. So it might be worth taking a moment just to unpack what a dead region is, and then we will be able to understand the concept of the threshold equalizing noise test. So what we have on the slide here is a very much simplified schematic of the cochlea. So we're having a look on the right hand side of the screen here. This is a slice through the cochlea, and we can imagine the cochlear spiral. Here's the basal turn of the spiral here, and then as we go up towards the apex, each time the spiral comes round, we can see a slice through it. And if we were to be able to zoom in and observe the sensory epithelia, the organ of Corti within the cochlea there, then we might be able to observe some pattern of hair cells. These are the mechanical transducers that convert the mechanical sound energy into a neural impulse. And there are two broad groups of hair cells. we can see here there's the outer hair cells and the inner hair cells. And I won't take too much time to describe these in detail, since that information can be readily obtained elsewhere. But just a couple of points to mention, that there's these key sort of functional differences between these two groups of cells, and it's these inner hair cells that are primarily responsible for converting the sound energy into nerve impulses. And those nerve impulses, as we can see from the schematic here, these afferent neurons then carry that sound energy as a neural code to the central auditory system. On the other hand, the outer hair cells, these are responsible for driving the so-called cochlear amplifier. This is responsible for providing the fine sensitivity and frequency selectivity and other properties of the normally functioning cochlea. And so when there is a typical age-related or noise-induced perhaps hearing loss which involves outer hair cell dysfunction, then what we might do is, for example, we might apply a hearing aid, and the aim of the hearing aid is to mirror the normal job of these dysfunctional outer hair cells in at least providing some degree of amplification, and it's usually in a compressive, non-linear fashion. Whereas if there was inner hair cell dysfunction, then no matter how much amplification we provided, it might be that the sound energy could never be converted into a nerve impulse. And so if there's a region on the basilar membrane that has such inner hair cell dysfunction, then a hearing aid may not be the best option, or certainly it may require a different strategy to the fitting of that hearing aid. So when there's such a region on the basilar membrane where there's inner hair cell dysfunction, such that sound energy, no matter how intense the sound, no matter how much it might be amplified from a hearing aid, cannot be converted into a nerve impulse, then we refer to that region on the basilar membrane as a dead region. Now, I've just to try and unpack that concept. So along the bottom of the trace here we have a schematic of the basilar membrane, and if we were to be able to peer down from a bird's eye view top down onto the basilar membrane there, then we might see from the top the stereocilia, usually 3 or 4 or 5 rows of stereocilia from the outer hair cells, and then a single row of stereocilia from the inner hair cells, shown in red here. And so that's normal hearing. And as mentioned, if we had some outer hair cell dysfunction, for example here we have some high frequency outer hair cell dysfunction, so that would be very typical of perhaps an age-related or noise-induced hearing loss, particularly where it's of a mild or moderate degree. And as mentioned, so the purpose of a hearing aid is to try and mimic the normal function of these outer hair cells in providing audibility. On the other hand, if we had inner hair cell dysfunction, usually it would be in combination with outer hair cell dysfunction as well, then it might be that these stereocilia from the row of inner hair cells were non-functional as well. And in this case, again, just to clarify my previous comment, no matter how much amplification we might provide from the hearing aid, since there's no ability to convert those sound waves into a neural impulse, then that amplification might be less effective. And it's this region. This would be a high frequency dead region, but of course there's a possibility to have a low frequency dead region, or even islands of dead regions that are surrounded by otherwise normal or certainly functional inner hair cell activity. So it can be, this is very much of a simplified arrangement here, and it can be more complicated than this. Of course, it is possible, there's another possibility that you might have inner hair cell dysfunction with no outer hair cell dysfunction, and then we would tend to give that pattern of pathology a different name. That would be described as auditory neuropathy, and type 2 auditory neuropathy in that circumstance. But that wouldn't apply to, of course, the consideration of a 10 test there. So we'll just move away from that. So here we have, in this schematic, an example of a high frequency dead region from 3 kHz and upwards, and if we were to test at 8 kHz as we do routinely, then we could call it a dead zone up to 8, but of course we know from our previous discussion that actually the human ear is sensitive to higher frequencies than that, and it might be that the dead region extends into the very high frequency range. So that's the concept of a dead region, and when the reason why the 10 test is relevant is that a normal audiogram can't differentiate a dead region from the same or similar thresholds, but without a dead region. So the audiogram on its own isn't sufficient to make a diagnosis and then manage accordingly. But it's nevertheless the case that if you were to see an audiogram like this, as I'm showing on the right here, where thresholds were sensory neural in nature, so not talking about a conductive loss now, but sensory neural hearing loss with a severity of around 55 dB or worse, then it's a reasonable assumption that there's likely to be inner hair cell as well as merely outer hair cell dysfunction. So that's how to recognize the potential for a dead region, and then it may be the case that you would apply the 10 test. And the reason why a dead region can't be differentiated using the pure tone audiogram alone is because of this concept of off-frequency listening. And this is the circumstance whereby activity, that's mechanical activity on the basilar membrane, that causes vibrations at a particular characteristic frequency, so a particular zone on the basilar membrane. Well, the hair cells that are tuned to that particular characteristic frequency, they may well be dysfunctional, but those that are tuned to a slightly different frequency may also detect those vibrations, but at a slightly lower degree. But nevertheless, if they're detected, then the person can hear that sound, and this is described as therefore off-frequency listening. And because they can hear it, then it means that they're are liable to produce, let's say, inverted commas, a false response. It's not false in the sense of that they're providing unreliable responses to the sound, but just that the place at which they detect the sound on the basilar membrane is not the characteristic frequency place for that sound. And so it could lead to the risk of underestimating the true hearing loss. But also because of this notion of off-frequency listening, it may also be that the part of the basilar membrane that is listening off-frequency, it will also be expected to detect sounds at its own characteristic frequency as well. So that you might expect a degree of neural distortion through the need to carry not only the on-frequency but also off-frequency sounds through the same group of hair cells and neurons. Now I'll just try to convey that concept by way of a schematic. Again, here's our basilar membrane here, and we might expect, for instance, for a middle frequency sound, some pattern of vibration on the basilar membrane, and as we increase the sound level and maybe also increase the frequency as well, then the pattern of vibration may well overlap, as we can see here. And if we study that pattern using this chart here, then we can hopefully pick up the concept of off-frequency listening. So what we have on the x-axis here is frequency. From left to right we're increasing, so this is characteristic frequency. And on the y-axis we have the extent of activation on the basilar membrane. So this is the envelope similar to what we were just looking at there. So the envelope of activation for a middle frequency sound at, for example, 55 dBs. If we were to increase the frequency of the sound as well as to increase the level of the sound a little bit, then we might end up with this second curve here, increase the frequency and the level again somewhat, and this third curve, and so on and so on. And what happened, what we can see here, is that there is a region, a characteristic place on the basilar membrane that is picking up activity to all of these different sounds due to the spread of mechanical vibrations on the basilar membrane. Now the peak of the response at each characteristic frequency is greater than it is at this off-frequency place, and so under normal circumstances the sound is perceived as being tuned to these relevant frequencies here. But if there was the situation whereby we had a dead region, for example a high frequency dead region like this, then those characteristic frequencies for each of those sounds, the place on the basilar membrane where the hair cells are normally tuned to those characteristic frequencies, they can no longer respond, and so what's left is this edge frequency and regions below where there's some smaller degree of basilar membrane excitation, and it's this region here that leads to the detection of the sound off frequency listening. So pure tone audiometry can't differentiate a dead region, although the pattern of an audiogram can indicate perhaps whether or not there might well be one there. The pure tone audiogram merely just tells us if a sound has been detected. It doesn't tell us whether it was detected by on or off frequency hair cells. So the solution to this challenge is the 10 test, and this was introduced by Moore and others in the UK a number of years ago. And the concept around this test is to repeat the pure tone thresholds, but this time in the presence of a noise, a broadband masking noise that's introduced to the ipsilateral ear, the test ear, and the purpose of this noise is to eliminate the possibility of off-frequency listening. So going back to the schematic here, then we have now the grey area, and that represents the 10 noise, the threshold equalizing noise. And the purpose behind it is, as you can see by the way in which the noise just covers the activation from the off-frequency, the place that was providing the off-frequency listening. So therefore, if there was a dead region, then suddenly the threshold would increase, because now the possibility of frequency listening is eliminated, and of course the dead region means that you can't have any on-frequency listening either. So if we apply the threshold equalizing noise and the thresholds then change, that suggests that the original thresholds were provided via off-frequency listening. So briefly, the procedure would be to do the pure tone audiogram as previously. If you suspect that there's a dead region, it might be that you could do a spot test at, for example, 3 or 4 kilohertz. Then you'd apply the masking noise and remeasure the pure tone thresholds. If the pure tone thresholds change in the presence of the 10 noise by 10 dB or more, then that indicates to us that there was off-frequency listening occurring. It may be that, of course, if there was a dead region, there was no detection now at all, and of course, because the dead region is essentially a profound hearing loss. So here's just a screenshot of a result where you can see the circles, and these are the pure tone thresholds without the 10 noise, and then the triangles, these are the pure tone thresholds in the presence of the 10. And they've all shifted downwards, so they've got more severe, indicating that without the 10 there was off-frequency listening occurring. So this is very useful to understand whether or not this off-frequency listening is occurring, because if it is, then what we don't want to do is overwhelm that edge frequency by providing too much amplification where it can't necessarily be detected or easily or provide benefit. It may just be that the detection is distorted due to the on frequency and off frequency listening at the edge frequency. Also, since we're talking about thresholds that are likely to be quite substantially raised, perhaps severe or even worse thresholds, then that would ordinarily imply high gain on the hearing aid and a tight-fitting earpiece. But if that amplification isn't going to be providing any benefit anyway, then it makes sense to just cut it out, which reduces or reduce that amplification, and then that reduces the risk of feedback from the hearing aid, as well as the discomfort from a tight-fitting earpiece. Understanding whether a dead region is present can also be useful in terms of the counselling of the patient in order to manage their expectations as to what can be achieved, as if there is a dead region, then that particular range on the of hearing is of course profound. And so in that case it can help as well in the identification of cochlear implant candidacy.